I'm as said, I just love survivors. I got into the field of survivorship when I was a lymphoma leukemia specialist at the University of Minnesota. Did my first transplant in 1984, so been around. Have a good colorist. I have a little hair still, but I took over, assumed the care of a patient whose physician had retired, and she was around 21, 22, and I had just seen her once, and she was back at work. She was a couple of years out and seemed to be doing well, been married over the past year, was excited about life again. She came in holding her side, and I saw her, you know how you see patients come to clinic. You learn a lot just by observing. You probably have known that. You know, you can tell where someone's feeling well, or they're having a tough day, things aren't going well. And I said, this is not her real name, Joan, what's wrong? And she said, I don't know. And she says, I think maybe I broke my ribs. And she was a young woman. I thought, oh, has she been out soccer, or what happened? She'd rolled over in bed. So she had such horrible osteoporosis that and she'd been on steroids for graft versus host disease. So I thought, my gosh, we're helping people live, but we're not helping them survive a quality of life. And so at that point is when I got involved with survivorship, and I've been doing it ever since. So I'm really here today to talk a little bit about some of the work that we've been doing at the National Marrow Donor Program. We have the resources. We have a large research arm of National Marrow Program Be the Match. I think some people don't realize that. Our research arm is a collaboration between the National Marrow Donor Program Be the Match and the Medical College of Wisconsin. And it has that horrible long name that we're thinking about changing. That's called the Center for International Blood and Marrow Transplant Research. Isn't that awful? CIBMTR. But your tax dollars pay for data, information about you, about your transplant to be reported to our research arm. So we have a huge observational database. So 100% of allogeneic transplants and how you survive and how you live are reported. And you may not remember that was one of those 29 pieces of paper that you signed before your transplant. And centers voluntarily report information about autologous recipients. And over 80% of autologous transplants are voluntarily reported. And you might say, why not 100? It takes time and energy, right, for a center to fill out forms and submit them. So we know a lot about survivors, and we want to know more. We have a special group within our research group that is really focused on patient-reported outcomes. Exactly what you tell us directly that's important to you. And so we're really excited, and I'm excited to tell you a little bit about some of the work that we've done here today and more about what we're doing in the future. So here's what we're going to talk about today. And you have a green sheet so you can follow along if you'd like. But I'm going to talk about what a personalized survivorship care plan really is. How many of you have one? I got one. Going for two? Anyone have a survivorship care plan? Okay. Well, that's good. We have something to talk about. If you did, we could go out and have a cup of coffee waiting for the next session. So we're going to talk about that, why you need one and how to get one if you don't have one. The role of your transplant center, your caregiver, and I loved that plenary talk this morning about how a caregiver is a co-survivor. I mean, I really think that's true. For the terms of the day to keep us organized, I'll use the word caregiver. And how to coordinate. How many of you just have one doctor? How many of you have two? How many of you more than two? Okay. Takes a while to coordinate among them. Who's doing what, right? Okay. So we'll talk about that a bit as well. So the survivorship concept really didn't start with transplant survivors. It started back with cancer survivors. And that kind of makes sense a bit about where the Institute of Medicine really looks out for health care in the United States. And so this was called From Cancer Patient to Cancer Survivor. They talked about patients that have survived their cancer. They're often lost in transition of that care between getting active care and then how do you go on with the rest of your life and what do you need. And so in 2006, the Institute of Medicine published this large document that laid out what cancer centers needed to be doing in order to provide optimal care of patients at the end of their treatment. They said that at the end of the treatment, so let's say that you had lymphoma and you were done, you should receive a care plan, whether or not you went on to transplant or not, okay? And it was supposed to include how to prevent, watch for, and look for any side effects of the cancer, how to watch for any new cancers, because if you've had one cancer, unfortunately, you're a bit at risk for having something else, and that coordination of care that we were talking about. So it took another 6 years, but what happened in 2012 is that the Commission on Cancer, and they accredit cancer centers. So cancer centers undergo formal reviews. And what the 2012 Commission said is that they wanted to phase in for the next 3 years, by 2015, survivorship care plans. So that for a cancer center to receive accreditation, which means they receive money, they receive support, they have recognition of being in an accredited cancer center, that the cancer center needed to develop care plans for their cancer survivors. And it had to be prepared by the principal providers who coordinated the treatment. So one person be in charge of it with everybody feeding in, so you have one central plan. Give it to the patient when they finish their treatment, and it contains a complete record of all the care received, everything about their disease, a follow-up plan based on the best evidence that we know now. They required that it be rolled out over 5 years. Okay? So they said, all right, we'll give you 5 years to implement this, such that by 2016, a quarter of your patients that receive care for cancer at your center have to have a care plan. 50%, and by January 2018, 75% of patients. But transplant patients were not at all addressed. This really just had to do with cancer. And as you know, many of our transplant patients don't have cancer. They may have sickle cell disease. Maybe they have aplastic anemia. Maybe they have Hurler syndrome and you're the parent of a child with an immune deficiency. So transplant patients were not addressed at all in these rulings. So welcome. Go ahead and have a seat. And there are some handouts that will get you, so you can follow along. We're just getting started and talking about the background of survivorship care plans. And so we in the transplant community were asking, is anyone focusing on transplant patients? Hey, we not only had a problem, we had to go on and even have more therapy. And the answer is yes. There are people that have been working for you. And here are the people that have been behind the scenes trying to make a difference in survivorship care plans. So the National Marrow Donor Program, Be the Match, the American Society for Transplant Cellular Therapy, they were known as ASBMT. As we mentioned, I started a survivorship special interest group, and we have patient representatives on this. I started back in 2016. We started with a small group, about 6 of us that was interested. At our meeting this year, we had 120 in standing room only of physicians that are interested in caring for survivors and helping move the field forward. And in fact, this is the Federation of Accreditation of Cellular Therapy. And why is this important? Because they accredit transplant programs. And in March of last year, they said for the first time that a transplant program has to have a survivorship long-term follow-up clinic. So if you're being audited, and you're being audited on that, so that's really making a big movement forward. So how many survivors are there? Well, we estimate that there's going to be almost 250,000 by next year, and 500,000 by 2030. All right, so you're standing strong, okay? And a lot of that is related to the advances that have been made over the years, that we're really able to help patients get through transplant safer. Older patients, the largest growing population of transplant recipients is 60 years of age and older, and we want older patients to be able to survive longer. But here's the problem, is that many survivors develop some health issues. Maybe these may be short or they may be longer, and it's just not recipients of allogeneic transplants that develop problems. is autologous patients as well. So I think some of us think, oh, you had an auto transplant, you must be back to normal by now, a year later. That's not always the case. And us survivorship transplant physicians are dedicated to making this better. But we have to have some knowledge. So if you take a look at this is a publication by Dr. Sun. And this was published 9 years ago. And this was the autologous transplant patients. And these are the ones that are allogeneic, had a donor. And this graded just complications, side effects, health issues, and graded them from 1, not being very much, not being very severe, up to 5, being pretty severe. And you can see here that both patients who gave their own stem cells for an autologous transplant as well as allogeneic, that overall 50% of them did have some health issues. And this was at 5 years out, and it didn't plateau. It kept climbing. Don't let this scare you. What this means is that we need to get in there and help, all right? Even as we age, all people have health problems, but we know that patients who age after having had a transplant are more likely to have some health problems, and it can be dependent on what treatment you had and what disease you had. And so you're not like everyone else. We need to make a care plan personalized just for you. So in 2012, I, along with several colleagues, joined together to create the first recommended screening and practice guidelines for survivors. And what I'm really excited about is that this was led by Navneet Mijel. He was one of my fellows. I have trained him, recruited him, and he's the president of the American Society for Transplant and Cellular Therapy this year. And so you have a professional in the society, our American Society, who is dedicated to survivorship. So I think there's going to be even more movement in survivorship this year. Okay. This was international. I put this up here just to show you that this was just not an American effort. This was European, Asia Pacific, Australia, New Zealand, Eastern Mediterranean, and the Latin Americans. So this now has become a global effort to help survivors. And in fact, we know that developing countries may not have the resources that we have here in the United States to help survivors. So we've said, what is the bare minimum? What can you do if you're a developing country? So I just returned last week from a meeting in India where I also spoke about survivorship. And they're working hard to try to do that, but with limited resources. So it really is a global effort, and one of the things that we can do to help that global effort is to provide guidelines and make it easily available for resources. Some of you may be very familiar with these. We took these guidelines that we published and we turned them into guidelines for 6 and 12 months and annually after transplant, both in paper form and then in an app. And it provides simple medical descriptions, a checklist to take with you. So if you have nothing else, this is really a great resource for you. And you can learn more at our booths here today. And we know that doctors need to be educated, right? So us in the survivorship field, we're really interested in it, and we have the guidelines in our head. But others who may not be so much may not, and they need to have an easy checklist. So these are based on the 2012 guidelines, and we're working to update them now. And I'm going to tell you about a little work that we did to try to update them. So why is this worthwhile for our transplant survivors? Well, each person had a different disease. You had different treatments for that disease. You had different treatments for your transplant. You have different age. You have different genetic makeup. You had different complications, different infections. You may or may not have graft versus host disease. All different things that are going on with you. And so you need a personalized care plans. And we think that education is empowering. Do you know, if you have a plan, I don't know about you, but if I have a plan, I feel a little bit more in charge. And I feel a little less scared, I feel less anxious. Okay, I've got a plan, here we go. And that plan's for me. You know, I feel comfortable with that. And so we really believe that if we can have uniform care that's based on the best evidence, and your research is showing this is the best thing to do, and doctors and caregivers and patients know that, and we can update it easily, it seems like that could improve care and that it could reduce the complications. Because if we know what the problems are, can't we work backwards and figure out if we need to do something different for different people to help them live longer and healthy? And so that's what we asked within the National Marrow Donor Program, within our research group. Can we develop a personalized care plan, and will it help? Will it help in any way? And so this is some work that we did. It was published recently, and so it's available to all transplant centers. And we fund our own research. So this was funded by the Patient-Centered Outcomes Research Institute that was created by the Affordable Care Act. And it is focused on research that helps patients. That's really all that they fund, patient-centered work. And so we thought, we're going to ask patients, what do you need? What do care providers need? What do caregivers need? And so what we started with is that we did focus groups. So we called and talked with folks. And we said, if we were going to create what's called a treatment summary, all the treatment that you've had, and a plan for a patient, what do you want it to look like? And so our bone marrow transplant recipients and caregivers, we gave them, this is what it looks like, should we change it? And it went through multiple changes, saying, no, you need to do this, you need to change this section isn't helpful, I need a place to put notes, I have to write down things, where do I put my questions, where do I keep my test results, I see 10 doctors, where can I keep that information? Then we also talked with the primary care physicians. So many of you go back to your hematology or oncology doctors, maybe at 200 miles from home, or you see a nurse practitioner, or you see a physician assistant or somebody in that office. And they want to know what happened to you down there. What did they do? And they may have gotten a summary that's all medical jargon, but does it really say what happened to you and how you can coordinate the care? What you're going to do, what I'm going to do, when the patient's going to come. We talked to the bone marrow transplant physicians, particularly those that weren't involved in survivorship care. What do you need? What makes it simple for you to provide this information to your patient? And we talked to the nurses and social workers who are often involved in coordinating of care as well. And so we developed things that I'm going to show you a little bit closer up. So this is an example. We created a blood and marrow transplant survivor treatment summary. And that would have the patient's name, the date that it was created, and then some medical information here, including important past medical history at the time of transplant, and then transplant information. And this is only one page of several pages. This transplant information would include what chemotherapy drugs you got, the doses. Some of those bother your heart, right? Maybe you didn't have a chemotherapy drug that bothered your heart, so you're different perhaps in what you need than someone else who did. Did you have radiation? Okay. Are you a woman? Did you have radiation to your chest that put you at greater risk of breast cancer? All those types of things go here. And then in addition, you have a survivorship care plan that's made just for you. And all these gray areas are areas that we can put in information that's dedicated just to you, that will have just your recommendation. And there's basic ones that everybody should have, right? But there's ones that you specifically need to have, and how often. So this was what we did. This was a study where we took the recommendations that were based on best evidence that we had published in 2012. And then we took this data. This is that research group that I helped lead. And these are the transplant centers. As I told you, that they routinely provide information on 100%. That's all the allogeneic transplants and over 80% of autologous transplants. So we know, and this is all de-identified, all right? That means that your name is stripped. You have a unique number. This is all anonymous, right? We'll make sure that you understand that. But we were able to incorporate a whole bunch of information about you, and this isn't even the whole list. You can only get so much on a slide. But we know what disease you had, what therapy you had, who your donor was, how old you were, what kind of transplant you had, if you had radiation or chemotherapy or mini transplant or big doses of transplant. If you had radiation, did you have graft versus host disease? Had you been on steroids? We know what infections you had. That's all there. And so it was no additional burden to the transplant center. They already gave this information. It's there. And so we figured out a way to use that and pull that into making the survivorship care plan for that individual patient. And so it was no burden to the transplant center and no burden for the patient. Okay. So this was a study that any patient who was 1 to 5 years out from an autologous, I feel like I'm in your way, autologous or allogeneic transplant could participate in with any disease, any type of transplant, any graft source. We wanted the disease to be in remission because they were getting additional chemotherapy. One, we didn't want to burden them and feel that the study would be hard for them. They could have had more than one transplant. So really we wanted to be generalizable. That's the word that's used in research, that we don't want to do something for this little big group of patients. We want to do something that then, if we get the results, it can go out to the general population. It works for everyone. And so they were randomly assigned, the patients, again, like flipping a coin, to whether or not they would get a personalized care plan within the first few months. And I'll tell you why the first few months. So we had 17 transplant centers. Some people say, well, how did you pick the 17 transplant centers? Well, we kind of picked our best friends. No, we didn't. We did pick some colleagues that we knew we really enjoyed working with and were really interested in the study because we needed to enroll patients. But we also wanted to make it representative of the population. So all the transplant centers weren't in Missouri. That wouldn't make much sense, right? So we have transplant centers that are scattered around. We want transplant centers that just don't serve people that look like me or my husband, right? We want transplant centers that serve everybody. We're a large, diverse group of Americans. We wanted everyone here. So there were 17 transplant centers, and they agreed there would be one person at each center that said, yep, we're going to help with this study. Let's get it done. And the patients had to agree. We just didn't do it behind your back. Patients agreed. And we made them a personalized care plan based on that information. And then our research group, they sat right outside my office, I hear them on the phone every day, called each patient, introduced themselves, the study, and did a baseline assessment of the things that were going on with them in their life after transplant. And then they were randomized, didn't get to choose, to what we call where they got their individualized care plan, or they didn't. Now don't think that's mean. Hold on just 1 second. So we made this care plan, and at 6 months after the care plan had been received by the patient, we called again and we did another assessment. How's it been? But then we sent the personalized care plan to all those that had been in the control group. Okay, so everybody that participated ultimately got their plan. So what were the results? So we had over 450 total patients that participated. That's quite a lot, to call and to do all the assessments on, and some weren't interested, but we had over 450, which means over 225, I think, that was about in each arm. But there weren't any differences between the groups in the confidence in their knowledge about survivorship information. So they think, oh, bummer, negative results. But no, actually, that's really good. I was really glad to see that we're at least getting some information to our survivors. And they're pretty confident about the knowledge that they have. But what we did find is that those who received the personalized care plan, is they were less anxious. They were less distressed. They were less worried about transplant and its complications in a whole variety of areas. The strain on their family, the demands from the care system, health burden, finances, financial burden, their impact on their ability to function, either physically or socially, and overall, The patients who received that personalized care plan immediately, didn't have to wait, had better quality of life. So we thought that these were really important outcomes. So we asked them also just some general questions. So how useful was the care plan in helping you to better understand transplant and related treatment? And the colors to take a look at are the yellow and the blue, are very useful and useful. If it was green and the orange and the purple, not useful, I didn't do it, didn't respond. So the majority of folks that participated in the study said it helped them to better understand the transplant and related treatment, side effects, how to manage your health, transplant and related treatment. Not also about side effects, but not in helping schedule appointments. And I wonder how this was worded, because somebody has to pick up the phone, right? Maybe we should have said, help you know when to schedule appointments with folks. And so they told us when we talked to them on the phone that they felt that was very helpful, but didn't seem to be much more helpful in some of these areas than those who got the care plan 6 months later. But here's some things that they also told us. It gave me a list of questions to ask my medical providers in one document. And before seeing the treatment summary and plan, I didn't know I was at a higher risk for certain cancers and problems. It got me to go for my mammogram, my blood work, my colonoscopy. You know, sometimes you feel like you've been through so much, you can't do one more thing, right? You just can't make one more appointment and go for one more test. But then if you see how it looks into the bigger picture, then maybe it can give you that little extra boost. The care plan and summary gave me a lot of confidence. And I don't know about you, but I think confidence can be one of the biggest motivators and help in surviving. It enabled me and gave me the knowledge to let the local health providers need to know. And we heard that frequently, that the local providers, and I'm not being bad, it's just transplant's a different world out there, right? It's different than doing well person care and minor health issues. But they're really, really good. And in fact, they're a critical member of the care team. They know more about the new high blood pressure medications than I do. They know more about how to treat high cholesterol than I do. I mean, I'm thinking transplant. They're thinking well preventative care. So for us to be partners in this benefits everyone, particularly the patient. It gave me an opportunity to dialogue with my primary physicians and other providers. Here, the orthopedist. It's been very helpful for my wife as well, so bringing in the caregiver. The plan's been helpful to me and my husband both. I wanted to point this out, that what we heard from the patients is that caregivers benefited by having this as a useful tool. In one place to be able to document. I was blindsided by the emotional aspect of getting cancer. Knowing the researchers were aware of the emotional components and something's being done about this is really empowering too. And the plan gave me permission to ask for help. You know, sometimes here's what I need, here are the biggest things, here's what I have. So we recommend that every transplant center provide a personalized transplant survivorship plan to all transplant survivors, regardless of age, type of transplant, graft source, complications, everyone. So what should it have in it? We've published this, but let me explain to you as well what your treatment plan should have. So it has to be the entire journey. Your transplant didn't start here. Maybe that was day 0, and to you that's in your mind. But for a survivor, in order to live well and live healthy, we have to know what's been happening here. All right? So that if you've had high blood pressure since you were the age of 20, and now you've undergone a transplant, we know that just having had a transplant puts you at higher risk of having high blood pressure. So if you've had it all your life, that's a flag, right? You're going to need to be monitored more closely. So I've divided this up into kind of the green, what we need to know before your transplant journey began, your pre-bone marrow transplant health concerns, everything that happened to you at the time of your diagnosis, before you even underwent a transplant. All of that therapy, that adds up to this whole journey. Your transplant therapy, whether or not you had graft versus host disease, infections, what medications you needed. Medications can have side effects. Some can be long-term. And so what happens then in your long-term journey? And we know everyone's a little different. If you were a smoker for 20 years, that's going to be a lot different in terms of what you're going to need for long-term. If you have a family history that everyone has heart disease in their 50s, we know that patients that have undergone an allogeneic transplant have heart disease 10 years sooner than the general population. So we need to know your entire journey. So what about the PreBMT assessment? This is your primary care. So this is where we need to work with your primary care physicians and your oncologist, hematologist. And so when you go for your transplant consultation, they provide information. It's often in the course of a cover letter and focuses primarily about your disease. Sometimes we get some of the baseline laboratory tests. Sometimes we know some about your past health. But a lot of times we don't, and often we don't even get the entire doses. So this behooves us as transplant physicians to work with your primary doctors and your oncologists and hematologists to get that information at that point of contact so that we exactly know all of the doses you received, what complications you had, did you have infections, have you had high blood pressure, have you had high cholesterol for 20 years, do you have heart disease in your family, all of those issues. That needs to be compiled. And so that's a point to our physicians at the very point of entry into the transplant world to gather that information. We need to know if you had radiation as part of that treatment, if you had immunotherapy, did you have surgery, and if so, where, what long-term side effects we may think about management. So that's one aspect of your care plan. And then you get to transplant, all right? So we need to also keep track of contact information if your primary provider changed, so that you always have in one area who's where and who's doing what. The conditioning preparative regimen, it varies for everyone, and as you know, with time it's changing, right? A patient that had a transplant last year's conditioning regimen may well be different than it was 5 years ago. That record has to be kept because each one of those medications or drugs or dose of radiation has a different side effect long term. How many people are getting immunotherapy, CAR T cells? I mean, everything is changing, and each one of them impacts your treatment plan. And radiation, we're really trying to get away from radiation. And why are we trying to get away from radiation? Because with research, we've learned that radiation can give long-term side effects. So really trying to get away from radiation in all of our therapies, transplant and pre-transplant. It's important to know the type of transplant. Allo is different than auto. Haploidentical. Did you have cyclophosphamide after the transplant? The stem cell source. The donor gender. So we know that if we can watch for disease coming back and whose cells, who's going to be doing that. The graft versus host disease. When I started out, there were a couple drugs to help prevent graft versus host disease. Now we have about 7 different ones in clinical trials. We have to know what you had. It was different. So that's the bone marrow transplant treatment summary. And that should be provided by the transplant center to you and to your other care providers. Okay? So you remember at the front desk, they ask you, who do you want something sent to? Give them a list. Do you know that know who to send it to if we have the list? So engraftment. Did there were any problems with your cells coming in? Did you need growth factor? Is that knowing that you had growth factor and how much? Is that going to be important now? Maybe not so much. It's important 10 years from now if we know there's issues with that. The graft versus host disease, the types, the parts of the body, infections, any other health issues that you had. All the medications, all the side effects, likely course of recovery, symptoms to watch for as you go back and transition to care, and even long term, that a skin rash to a primary hematologist and oncologist may look like a reaction or eczema. To us, it may be the beginning of chronic graft versus host disease. Okay. Oh, and I wanted to make one more thing. Symptoms to watch for plus what to do, who to call, and who to see, right? So who's going to manage that? Is it a patient's responsibility to call the primary care provider, and the care provider says, I'm not sure what that is, check with the transplant center, then you go home, then you call the transplant center, Or does the primary oncologist in the center say, Mrs. Jones is here, she has a rash, I'm not sure what it is, an appointment's made and you have it taken care of and a plan made. That's different than you say, okay, then I got to go home, then I got to call and wait for a call back, okay? And the long-term follow-up care plan. So this is a schedule of all of your planned follow-up care according to a personalized plan for you. Who's going to schedule it? Who's going to provide it? Where is it going to be done? How often the visits are needed? What tests are needed? Why they're needed? Why they're needed is incredibly important. What visit they're going to be done? Who's going to order them? And who's going to tell you the test results? And what they mean? And what's the impact for you? And does your care plan change? Okay, care plans will have to be kept updated because your lives change. So how to use your plan? Refer to it often. Use it to know when to schedule appointments and which provider. Take it to all your visits. Use it to ask questions, take notes, record what was done, what the results were. Those results belong to you. You know, my dad goes to the doctor, he's 94, and he has something done, and he says, well, Linda, they told me there was a little bit of a problem, but they'll keep an eye on it. I said, well, you know, if you'll tell me or send me a copy of it. Well, I don't know, I don't have the copy. Do you remember how I'm standing there with a glass of wine in my hand? I shouldn't be saying that. My hand starts shaking, right? I have a glass of white wine. It was a nice evening so far. And then I'm just like, my father, how many times have I told him, please, Dad, just ask for a copy of your results. They belong to you. Your medical records are yours. And, you know, as a physician, if I had a CAT scan result, one of you pull up on the screen and you hand them the results. Hand your patient and make sure they understand in lay language what it meant and what we're going to do about it. So it is your right. You know, I try to move patient care and physicians and how they manage patients, but those are yours. Make sure you have them and that this has been explained to you. And if the doctor doesn't have time, the nurse, the coordinator, please make sure that you ask. I want you to know. And I also, did I say this, to share your plan with your caregivers. So your caregivers are an important part of your support team, all right? So that they can help you coordinate all these visits, remind you. And it's really helpful, I think, for parents to be able to keep track of all of these things that's going on with their child. And pediatric transplant survivors are unique. I mean, they're the other end of the spectrum of an older transplant recipient because those kiddos are changing and their lives have really been impacted in terms of their growth, and they have a much larger span of potential late complications if they underwent a transplant at 2 than someone who's 75, all right? So we have to keep that span alive. So what if you don't have a care plan? What if you never had one? And what if it's old? Okay, what do? Well, first off, would ask your transplant care team to prepare one, all right? And then not only prepare one, they just don't mail it to you, they review it with you. And so it may take them time, if they're not used to doing this, of pulling up medical records and putting together a care plan for you. Ask about anything you don't understand. If you had a care plan but was several years ago, it probably needs updating because things have changed. We know more than we did even 5 to 10 years ago about what's best for transplant patients and what testing should be being done. And your care needs may change. If you've developed hypertension, if you're now on medications for thyroid disease, those may need to be updated. So is it really that important? I hope I haven't overwhelmed you. And you're going to walk out of here thinking, God, the morning was going so well. I was a hero an hour ago. now I'm a hero in need of a care plan. God, I was doing so well. But it is important. And you don't have to rush right out and do this right now. It's a beautiful weekend. It's double the temperature that it is in my hometown this morning. So you don't have to do that. But the next time you have a visit, even if it's your primary doctor, your oncologist, or you're down for the transplant center, say, I don't have this. I'm hearing about a treatment summary and care plan. Could you help prepare one for me? And it may take them a while to pull together the information. But But I think it really will help you. And the best thing, what we're really looking for, is to prevent complications. Because a lot of these are preventable. If you just know about them and can watch for them. Okay? So here's my take-home points. A personalized survivorship care plan is critical in maintaining good health after transplant. Your transplant team should provide one for you, help keep it updated, take it to your appointments, use it to keep track of what needs to be done, and share it with your caregiver. And I just want to acknowledge these were all of the transplant centers that participated in this study. I want to thank all the patients and caregivers who gave time. Our patient services advisory group, so we have patients and caregivers who are an advisory group for us who also reviewed all of this and provided comments. Our research program and our funding. And what we've done with this is now we've moved to the next step. So we are now funded by the National Institutes of Health, another large study. We've just finished and published more focus groups with patients and care providers. And we've developed a mobile app, an upgraded one that will provide health care on an interventional level. So it's, the PIs are at the Fred Hutch, Cleveland Cancer Center, and National Marrow Donor Program. We've just completed all the focus groups and published them. And so the next iteration of this will be started. It's a 4-year research study. So it takes a lot of time to sort some of these things out. But in the meantime, this is the best we have right now. It's published. The University of Nebraska just contacted me this week and wanted copies to implement into their survivorship clinic. So feel free to use my name. We can send them, stop by the booth. And I had one more announcement to make, is that if you're interested in helping, if you had a transplant within the past year, we're asking patients what they wish that they knew about clinical trials. So if you're interested, you're an adult, had a transplant within the last year, please stop by our booth. It will be a phone conversation. We want to hear from you. So thank you very much for your attention. We're going to have about, not quite 15 minutes. And if you have any questions, I'd be happy to take them so everyone can hear, or also be hanging around so you can come up and talk with me personally. So thank you very much for your attention.
I do have a couple questions.
Sure.
It sounded great. And how many people put their hands up that
one.
had a plan? Okay.
There was one.
that means most of us don't have a plan.
Yeah.
What are the I saw those 17, participants, but what if you're at a Northwestern or a University of Illinois at Chicago and you go and you say, hey, I just went and I heard this
talk
and now by law, did you say by law or it's being funded by the ACA?
So that was in order for a cancer center to be accredited.
Okay.
But it's interesting, if you read the language, it's cancer patients.
So when we go to them, and
you go to them,
they're going to look at us like we have moon eyes. Like, what the heck are you talking about? We can't do that. We can't get your chemo. How much chemo we gave you, and what kind of report are you looking at? But do they have the format of this report?
Yes, and it's published. It's there, and you're asking me, well, could you send it to every single transplant doctor in the country and all the hematologists, oncologists, so they have it? But it's right there.
So we should go to our transplant center.
And they can contact me. If they don't know how to reach one, they can contact me. Yeah, you could even just give them my name. But it's in the transplant literature. It has been published in our national journals of the transplant societies in the United States. I mean, everyone reads them, it's global, but we put it in the journal that every transplant physician should be reading. Yep, it's there. And you're going to say, yeah, Linda. Yeah, I know. You look like my dad when I tell him something. You're like, yeah, Linda, I'm not so sure this is going to work, but...
The best I can say is yes, the worst I can say is
no.
no.
And also just pick up some information. NMDPs are patient navigators.
Yes.
So a simple phone call, if they contact the patient navigators at NMDP, we'll get it right to them. And, yeah, we'll get it right to them. So if anyone wants it, yep.
That it was what I was going to say. I'm a patient navigator, and I have the booth there. And if you call, we'll help you, and she will give it to us, and we'll.
That's what I'll
give it to
do.
you, and you can go with your doctor.
So if anyone's interested, stop by the booth, pick up the patient navigator information. Doctor can just call there, and we'll get it right to them. Will that help?
Yep.
Steve? Yeah, you've got to know. You can't walk out of here and say, well, that all sounded great. Yeah. Sound like I won the lottery, but my God, I lost my ticket.
I'm 15 years old, and it took a lot of courage for me to actually sit down with my doctor and explain to them that since transplant, I've had a hip replaced, shoulder replaced, C. diff, first appendix, all kinds of things. But sometimes we're afraid of how they're going to react, or they're going to give you that kind of stern look or something like that. You got to do it from your heart, and you got to look this person in the face, and this person has to have this kind of open stance, like they're ready to listen to you, and you let them know what you need. I need this. I need this.
So did that work for you?
Sort of.
Sort of.
It's in the process.
Yeah.
It's you have to keep talking. It's not, they're not going to react on the first or second try. You have to keep trying.
So it is, it's going to get better. It is that we knew about 5 or 6 years ago that there were around 30, 35 long-term follow-up clinics in the United States, at certain centers. And with the awareness, raising awareness through multiple methods, that through NMDP, we just completed a survey of every transplant center in the United States. And I got a 100% response rate. I nagged everybody. I called them. I emailed them multiple times. Rob, if you don't answer me, I'm going to call you tonight at 7 p.m. and interrupt your supper. But 100% got back, and we know now every transplant center in the United States who has an adult program, who has a pediatric program, and who runs them. And we are launching an in-depth evaluation of all those centers about best practices right now. So awareness is growing. Awareness is truly rolling. And the thing is that we're putting that on the public website for NMDP. So those people that sit up on the 7th floor that are smarter than me, and all I know is that when something doesn't work is I reboot, and if that doesn't work, I'm done. But those people know how to do stuff. And so they're putting it on our public website so that any person can go on and see where their closest survivorship clinic is that provides survivorship care, whether or not they provide pediatric, adult, if they accept survivors regardless of where you had your transplant at. So that's a public service. We're hoping to have it up and running this summer. But we did the survey first. We closed it. They're working on it. You can go online, be the match, plug in a state, and know where expert survivorship care is. So I should have put a slide up that becoming, I don't know if it's all up there yet. We started. I don't know if it's all up there yet. I should go in and look. But that was been my goal. Oh, shoot. To get that up by, I'm an experienced speaker, to get that up by this summer, but watch for that too. And that might be really helpful. And we thought it would also be helpful that if people relocate during wintertime, I know in Minnesota we have a lot, the state just empties out. It's like college is out. But if you needed survivorship help, you would also know if I'm in Arizona, where's a survivorship clinic and I can call. I need someone to help me. I'm a survivor. I need help. Yeah.
And Linda, as somebody coming from a transplant center, I mean, survivorship makes sense, and it's great because we have so many survivors. This wasn't as big of a challenge, 15, 20 years ago.
No, we're lucky.
Yeah. And as somebody that's coming from an area that there's a lot of, I'm going to call you snowbirds, but snowbirds that come down, we do a lot of that. And the doctors have the patient's best interest at heart. And if you go to a doctor and they don't seem to have the patient's best interest at heart, I would recommend you go to that website and find another.
Yeah. But if you have your survivorship care plan and you know that you're going to be gone for 6 months and you need to have this and that done, you've got it right there, and and there can help be coordination of care for an appointment for you to get your work done while you're gone.
We've got a question back
that can
here.
be helpful. Yeah.
Hi. You mentioned in the beginning that this was part of the Affordable Care Act, funded by the Affordable Care Act.
We were funded. Who gave us the money to do the study that we did is PCORI. It's the Patient-Centered Outcomes Research Institute, and it was created as part of the Obama Affordable Care Act.
Yes. Isn't that kind of a political football going on right now? And what would happen to the program if it
Yeah, I think
goes
it's a
away?
real good question about what would happen. PCORI is an institute that funds this type of patient-centered research, and it's just not for cancer. They fund all patient-centered research as a study section put through. And there was concern about whether or not the funding for that would go forward, and so far it is. They're continuing to fund everything. I think it was felt to be so important by Congress that, but there was a little concern a couple of years ago. But they fund interventional studies, such as this one. They fund, actually put in perhaps a request for funding for post-transplant stress disorder after transplantation. They fund a whole variety. They're very interested in telehealth, which I think is going to make a huge difference for survivorship care. That if you live some distance from the transplant center and can speak with a survivorship expert and not have to travel 200 or 300 miles. So they're very interested in telehealth right now. So they're a wonderful funding agency that's really, I think, promoted patient-centered research. It's a good question, but so far so good. Yeah. Yeah.
I have a question. You said there's 240,000 survivors in 2020. I'm just curious of how many transplants are actually performed a year.
It's about, so that was just in the United States survivors, I think. That's not globally. So there's a difference between whether or not there's the United States or globally. In the United States, there are, I want to say, around 11,000. Yeah. We facilitate, I've got the slide on my computer. I should pull it up. I'm giving that talk next week. There's more autologous patients than allogeneic patients performed in the United States, but it's in the thousands. Yeah.
Another question.
And so, in the early days, there weren't that many survivors, unfortunately. So it's been within
What's the early days?
1978 to 1980. I was, as I said, I did my first transplant in 1984, and at that time, the risk of dying from an autologous transplant was about 15 to 20%. Today it's less than 1. And for allogeneic transplants, the chances we're dying were approaching up to half, and now we're down at 15%.
How much
And
of that
then-
is age-related?
And then patients died from complications after transplant. Yeah. Age-related, the fastest growing population is 60 years of age and older, because now we know that outcomes with scientific advances are the same for older patients as they are for younger patients. So the fastest growing population is 60 and older.
Another question, are the transplant centers that you had listed, that you got the interest that you're working with? Two notable absences, from my perspective anyway, was MD Anderson and Dana-Farber.
Mm-hmm.
Why aren't they involved?
Yeah, so there were a large number. There's almost 140 transplant centers in the United States, and those were the ones that expressed interest, okay, in doing it. That said that they would be able to enroll patients and wanted to work with us. So we couldn't manage every transplant center in the United States. Every has to go through their IRB, and we want a diverse population. So it really mattered about whether or not they wished to work with us, that they wanted to enroll patients. So not every center, I'm asked that every time I talk about this, that my center's not on here or whatever, but and at the time that study was initiated, we wanted a mix of those that actually had survivorship clinics and those that didn't. So there's a lot of things that went into that. So it wasn't they're bad centers or they don't do research. Those are great centers, friends everywhere. But just geographic diversity as well in picking centers. Any other questions? I'll take hers. Yeah.
On one of your slides, you'd commented on something that actually made my brain started working a little better. Okay? You'd commented about the stem cell source and donor gender. Well, I'm a 3-year survivor, and I was wondering, how does the donor genetics affect me now and perhaps later?
So donor gender and donor genetics.
Yeah.
So a couple things. Donor gender is really important to know, primarily in terms of following your disease. If the disease would start to come back, particularly if you were a woman and you had a male donor, that you could often easily tell if your cells were starting to come back, because your cells would be female and those cells would be male. All right, if you'd had a male donor, then you would have to do additional testing to find out whether or not your cells were coming back and you were losing your donor cells. Does that make sense?
Yes.
Yep. So that can be important to know. In terms of other things, it's not the donor's health issues or things. Really, it's male or female. And the donor graft has to do with whether or not it's peripheral blood stem cells, whether or not it was bone marrow cells, was it an umbilical cord blood. Each one of those may have potential longer-term side effects. So that's what we mean by graft source.
Okay.
Does that make sense? PBSC, bone marrow, umbilical cord. Yeah, and now we're doing engineered grafts. Well, they have different long-term side effects if the graft has been engineered. So those are some of the key points. So taking out some T cells, alpha, beta, delta, re-engineering them. Were NK cells left in? Were they left out? Those kind of things. Yeah, so engineering. Sure. Yeah.
This will probably be our last one, Linda. Just to.
Oh, yep, Cynthia, go ahead.
Thank you. You mentioned earlier that the doctors has a site where they can get the information from. But as patients, is it possible for us to bring paperwork to the doctor so that they can just fill it out instead of asking them to look for it somewhere else?
Yeah, well, that's a really good point, and perhaps we should just go ahead and post the treatment summary. The simple ones are available that I showed you, the 6-month, the 12-month, and on the app. All right, those are not, and they certainly can take those and personalize them to you. But the work that we've done in terms of exactly what things can be personalized is so. We'll talk. I'll talk with NPP, but those are available right now. The very basic ones are available. They're on an app. Did we bring any for the meeting today? The 6-month to 12-month survivorship care plans? Come over and we'll provide that information to you. And they also have available on their app, and that all that information is on our website. Yep. But come by the booth. Yep, and all that's there. Sometimes it can be hard to find things on the site. So thanks very much. Really appreciate you coming, and you're all survivors, and congratulations to all of you today.